Welcome, and thank you for joining us for another webinar in our professional series. I'm Cynthia Milburn, CEO of Epilepsy South Central Ontario. We are the community support agency for families and people living with epilepsy and their caregivers, covering a large area of Southern Ontario west of Toronto. Today, we welcome Dr. Elizabeth Kerr to share her knowledge and experience. Dr. Kerr has been a neuropsychologist and health psychologist with the Departments of Psychology and Neurology at the Hospital for Sick Children, Toronto, Canada, since 1996. Over her career, Dr. Kerr has continually worked with children and adolescents with epilepsy. She provides neuropsychological assessments with the Epilepsy Surgery program, is the program director for the remedial and treatment program for children living with the cognitive and social consequences of epilepsy, was a consultant with the Ontario Ministry of Education for Prevalent Medical Conditions, and is among the hub team of experts for Project ECHO, Epilepsy Across the Lifespan. Dr. Kerr is currently working with others to develop strong material to educate educators about epilepsy and the cognitive, psychological, and social consequences of the condition so that students can be better supported at school. Dr. Kerr is the director of the Epilepsy Classroom located at Sick Kids Hospital, and several of our camp participants have attended this specialized classroom at one time or another, many of whom have blossomed into productive, successful young adults, subsequently becoming leaders, CITs, and camp counselors at our Sunny Days camp. We have an amazing feedback regarding the experiences had at the Epilepsy Classroom, and Dr. Kerr, I welcome you.
Thank you. Good morning, everybody, and thank you for joining us. I want to thank the Epilepsy South Central Ontario for inviting me to speak, and it's my pleasure to talk about the comorbidities of epilepsy with you. I am focusing on children and youth, and I often refer to the comorbidities actually as co-occurring conditions, and hopefully after the presentation you'll understand why that is. I am going to use a few slides, quite a few slides, to help with the attention and also the explanation. And my talk is about 25 minutes, and so there should be lots of time to answer any questions that you may have. So I'm just going to get my presentation up. And I hope everybody is able to see that. So we've known for a long time that epilepsy is far more than a seizure disorder. For children and youth living with the condition, it can be a frequent cause of disability. Recognizing that, in 2017, the International League Against Epilepsy updated its definition of epilepsy. And so it now reads as epilepsy is a disease of the brain characterized by an enduring predisposition to generate epileptic seizures and by the neurobiological, cognitive, psychological, and social consequences of the condition. Today, what I'm going to do is I'm going to talk a little bit about brain functioning, really in order to provide a foundation for talking about the types of cognitive, psychological, and social consequences that children and youth with epilepsy may face. So it's a little bit about Neurology 101. So our brain is made up of microscopic cells called neurons. And this is a single neuron or nerve cell in our brain. And we have about 86 billion neurons, as well as several trillion connections among them. The neurons communicate with each other through electrical impulses triggered by activity of neurotransmitters, or chemicals are released which do different things. So all of the brain functioning is about electricity and chemicals, and the system is interconnected. The electrical physiology overall of our brain is often compared to a complex electrical system in a big city, such as Toronto. Everything that we do, say, think, and feel is a result of the electrical signals that are generated by the neurons in the brain. So we probably have little microcircuits in different areas of the brain that relate to very highly specialized skills, such as word retrieval. But many of our cognitive, psychological, and social skills rely on distributed networks within our brain. Unfortunately, when there's interference or damage in the networks, then effective communication between the different brain regions is prevented, and the functioning that was supposed to happen is also prevented. So interference might be a seizure, and a seizure is caused by abnormal, excessive neuronal activity in the brain. Damage might be what I will say is an underlying brain abnormality, or could have been a head injury or something like that. The disruption that we see in terms of our functioning might be transient, such as when we have interictal discharges, there's a seizure, or it may be more permanent, and that might relate to structural changes that have happened in the brain. So alterations in and disruption in brain structure are some of the influences on brain functioning. The other epilepsy-related factors related to brain factors or functioning include anticonvulsant medications. So not all children with epilepsy experience medication side effects. Side effects are most likely to occur when a new medication is introduced, the dosage of an existing medication is increased, or when a child is on more than one medication. The types of medication side effects that we frequently see are fatigue and drowsiness, slower speed of information processing, difficulties with attention or memory, and changes in mood and behavior. Genetics is also an influence on brain functioning. So for genetics, when we look at twin studies, just of any individuals, not necessarily related to epilepsy, and we look at the intellectual functioning, we see that about 40 to 80% of intellectual functioning is explained by genetics. We also know that part of temperament is explained by genetics. For epilepsy, there are some epilepsy conditions that are related to genetic syndromes as well. So genetics has an influence on brain functioning. A third influence on brain functioning is developmental timetables. So our brain starts developing in utero, and then it continues to develop up till about 25 years of age. So this picture is really looking at that development with the greatest development in that dark blue and the purple zones. A lot of development for girls is done by about 11 years of age, and for boys, it's about 13 years of age. But this frontal part of the brain really continues to develop up until we're about 25 years of age. And that area of the brain is called the prefrontal cortex, and it's been referred to as our wise leader. So it's responsible for judgment, decision making, organization, and planning, all the skills really necessary for success in adult life. Interrelated with developmental timetables is the environment and our experience. So it's really well recognized that the brain modifies itself based on the experience and the interactions that we have within our environment. And this is known as brain plasticity or neuroplasticity. And essentially, the brain really has this remarkable ability or capacity to reorganize pathways and create new connections among the neurons as a result of the learning that takes place, and sometimes in response following injury. Plasticity occurs throughout the lifetime. However, the brain tends to change to the greatest amount during the early years of life. So together, I'm going to call those the developmental trajectories on brain functioning. Because of each of the influences on the brain, for each child or youth living with epilepsy, the consequences of epilepsy in terms of related cognitive, psychological, and social abilities will be different. Children with well-controlled seizures may have different issues than those with poorly controlled seizures. Those with highest risk for cognitive, psychological, and social consequences are those with a history of infantile spasms, having an early age of seizure onset, having more than one seizure a day, having what's called focal epilepsy, and being on more than one anticonvulsant medication. What I'm going to do now is I'm going to go through some of the most frequent cognitive issues that we see, and then the frequent psychological, and then talk about social issues. When we look at studies that have been done worldwide, we see that the majority of children living with epilepsy experience some type and degree of cognitive challenge. So it may be very minimal, it may be very specific, or it may be more severe. Intellectual functioning is probably the most understood or general term for cognitive abilities. If we just took 100 people off the street of a given age, we would expect the intellectual functioning to fall in this bell-shaped curve, where just over 68% fall broadly within age expectations. About 16% fall above age expectations to varying degrees, and about 16% would fall below age expectation to varying degrees. But we only expect 2 out of 100 people, or 2%, to fall in the very low range. With epilepsy, what we see is that this distribution is shifted downwards. So when we consider all children with epilepsy, so those who are well controlled on medication and those who are not, about 25 out of 100, or 25%, actually fall in the extremely low range and would be given a diagnosis of an intellectual disability or developmental disability. But of course, we still have individuals who are falling broadly within age expectations and some that are falling above age expectations as well. Intellectual functioning fails to capture the complexity of cognitive functioning that we see. There's a lot of different skills that are related to cognitive functioning, including social emotional functioning, and I'll talk about that in a little bit. For epilepsy, even when intellectual abilities appear to be broadly age appropriate or stronger, weaknesses in processing speed, attention, and memory are frequently observed. And you may recall that those are the same types of cognitive issues that may occur as side effects of medications, and they're also the same cognitive concerns that adults with epilepsy face. For children and youth with epilepsy, the other area that I will address is academic progress, because it's a frequent concern of parents and teachers. So looking at attention is probably one of the greatest cognitive concerns that are raised by parents and teachers. And I think it's really important to highlight that the issues with attention often present prior to the first seizure. So if I look at report cards of a child that I'm seeing, the teacher may have already recorded that the child was distractible or had problems with focus, needed frequent reminders to pay attention. Sometimes the child coming to see me will have had a diagnosis of attention deficit hyperactivity prior to their first seizure. When we look at attention, the most pressing concern or problematic concern are difficulties with attention, sustained attention. And sustained attention really relates to the ability to stay focused for a long period of time, particularly if something is boring. So as this illustration shows, being in a classroom setting and following a lesson. Playing video games, watching TV aren't really very good measures of sustained attention. One, because the child's highly motivated to do it. And the other is because both of those activities have lots of bells and whistles that draw a child's attention back into the activity. When we look at children and youth with epilepsy overall, about 33% will meet criteria for attention deficit hyperactivity disorder. That is an umbrella term where we have inattentive subtype, we have impulsive hyperactivity subtype, or a child might have both. In epilepsy, it's the inattentive subtype that's most common, although we do see children who are impulsive or hyperactive. ADHD in children with epilepsy often differs from classical ADHD in that girls and boys are equally impacted, and the fact that the inattentive subtype is more common. There was some older literature that suggested that stimulant medications may lower the seizure threshold, and so a lot of families didn't want their children on stimulant medication. It's very old literature. The current literature indicates that stimulant medications are not contraindicated. The risk for lowering the seizure threshold is very low. And in fact, there's substantial research that documents the positive effects of stimulant medication for children with epilepsy. The next area is processing speed, and that's often referred to as mental slowing. And what we see in epilepsy is slow or inconsistent processing of information or variable responding. So an example just from my classroom is that I'll see a child put up their hand, and by the time we get to them, they may have forgotten what they were going to say, or I've taken a long pause and I think that they've forgotten, but then they come up with a brilliant response. It's just taken them a long time to get the information out. There was a research study done in Sussex, England, of children with active epilepsy, and on formalized testing, they found that 42% of children with active epilepsy displayed weaknesses with processing speed. And processing speed has implications for a number of different skills. What's not listed on this picture is the ability to follow a lesson in class. So they're going to hear a little bit, they're still thinking about it, they're going to miss the next two things, then they're going to tune in, and that comment by the teacher doesn't make sense because they missed the pieces in between. They may only be able to do follow one instruction rather than 3 instructions, for example. I'm bringing in working memory. Working memory does relate to processing speed, and it has implications for sustained attention. So working memory allows a person to hold, process, and manipulate information in mind very briefly in order to complete complex cognitive tasks, such as learning, reasoning, planning, and organization. It also helps us form long-term memories. The important piece is that it operates over a few seconds, and it's a temporary storage. It's not a permanent storage. In looking at memory, with children and youth with epilepsy, we see problems with consolidating, retaining, and transferring newly learned information. So, I have lots of parents say that my child studied really hard for the test only to forget it the next day. Or I have families tell me that following a cluster of seizures, that their child forgot how to do some certain skill or forgot some event that happened, even a wish trip, for example. The types of difficulties we see include difficulties with short-term memory, so forgetting to do chores or to bring home homework at a higher rate than would be expected for somebody their age. We see difficulties with autobiographical memory, and what that really means is remote memories for events that happened, such as a birthday party or a trip that they went on, something that they experienced. And the other area of memory that we see frequent issues is in terms of word retrieval. So getting out the words that they want when they're needed, only to come up with it later. In looking at academics, over 2/3 of parents and teachers report difficulties with their child's or student's progress, and that might be related to the difficulties with attention, processing speed, and memory that we see, and then the associated frustration that comes with that. But even on formalized assessment, we see that up to 50% of children living with epilepsy may be underachieving in one or more subjects. So I'm now going to turn to psychological and social consequences. There are numerous interrelated psychological and social consequences. So I'm going to do one slide that kind of combines everything and then look at them both separately. So we see in children and youth increased feelings of differences due to their academic difficulties, but also because they're living with seizures or epilepsy. We do see increased impulsivity. We also see increased moodiness and irritability. Children and youth with epilepsy do seem to experience more peer difficulties than their peers, primarily related to bullying and teasing, and also being left out because of that. We see more embarrassment in general, largely due to having seizures in public. And then we also see some anxiety and uncertainty due to the unpredictability of seizures. We also see decreased ability to inhibit responses, so blurting out answers or making comments that shouldn't be made. We also see some decreased autonomy, which I'm going to talk about in a little bit, social competence or self-esteem, and lower social skills overall. The psychosocial issues can vary from being very mild to more severe, so very similar to the cognitive weaknesses that we may see. And they may have a great impact on the child's ability to do their daily activities and on their quality of life. So when looking at diagnosed psychological conditions, other than ADHD, the most frequent diagnosed conditions are anxiety and depression. The symptoms associated with anxiety and depression are often seen as crying, irritability, or physical complaints, sometimes withdrawal, rather than the obvious worrying and changes in sleep or appetite that we typically associate with those conditions. So the irritability and the crying may actually mask anxiety and depression. Anxiety can occur as a reaction to the diagnosis, the symptoms of the seizures themselves, unpredictability of the seizures, or a side effect of some of the medications. And really, depression occurs for similar reasons. The diagnosis of these conditions is almost 5 times higher than children and youth in general, and they are also higher than peers living with non-neurological chronic illnesses such as asthma. The rates are higher among children and youth with complex epilepsy. So we see rates of up to 50% in children with complex epilepsy. These types of emotions have a really impact on our ability to learn. Stress and anxiety can make it very difficult to concentrate and process information effectively. In looking at the social consequences of epilepsy, just like the cognitive abilities and psychological functioning, weaknesses in social competence are presumed to relate in part to the epilepsy-related factors that we talked about. Additionally, they might relate to the developmental timelines, and they are going to relate to some of the, sorry, I lost my mouse, to some of the psychological comorbidities that we've talked about. We do know that depression and anxiety in patients with epilepsy contributes to the risk of impaired social relationships. Cognitive functioning can also give rise to social difficulties. Specifically, reductions in information processing speed and working memory may make it more difficult for a smooth social encounter. They have trouble following the conversation because they can't keep pace with it. Inattention and weaknesses in executive functioning, including distractibility and lower inhibition, can also disrupt communication and social reciprocity. And an individual may have difficulties with social cognition. So social cognition is really related to understanding social nuances, such as reading facial cues, for example, or the tone of somebody's voice in saying something. And it's also related to perspective taking. The other piece that I'm going to add is the effects of stigma. Unfortunately, stigma for epilepsy does continue to take place. For an individual child, the other piece is fear of having seizures or unpredictability of having their seizures in public. And then another piece related to social is the role restrictions that a child may face. And I'm going to talk about that also in a moment. But these types of things can impact on a child and youth's social engagement, as well as their ability to learn and practice social knowledge and rules so that they can develop competency in those. Not surprisingly, we do see higher rates of withdrawal among children and youth with epilepsy. Feeling of social isolation or rejection due to epilepsy also may influence their psychological well-being, such as anxiety and depression. So when looking at social functioning, I want to talk about autonomy, and autonomy refers to the state of being independent or self-governing. And what we know is that the effects of ongoing seizures, medical appointments, and hospitalizations, close adult supervision, can delay the development of independence and emotional self-control. There tends to be an over-reliance on parents, hesitation over decision making, and as a result, slower transition to full adult autonomy. In doing assessments, we will look at adaptive functioning, and we can use that through a parent or a teacher report to look at how independent a child is. So adaptive functioning is looking at the social cultural standards for personal independence, and it could be related to their social functioning, practical performance, cognitive skills, personal living skills, for example. Studies that people have done, including myself, show that even when children have typical intellectual abilities, they display limitations in adaptive functioning relative to what would be expected given their intellectual functioning. So in looking at autonomy and adaptive functioning, in order to meet the normal milestones for their peer group, children and youth may need more support. I would say that that's probably where some of the epilepsy associations come in. They may do group programming, they do camps, and so forth to be able to support kids have better social opportunities. I'm just going to raise autism and autism spectrum disorder, or epilepsy and autism spectrum disorder. It is a social condition. Approximately 20% of children with epilepsy have autism spectrum disorder. The majority of children with epilepsy who have autism also demonstrate an intellectual disability, but that's not in every single case. A full understanding of the possible links are pretty vague at this time. The research does suggest that there's a common underlying predisposing factor because many of the epilepsies and autism have genetic components to it. In terms of treatment, there are some case reports in open trials that suggest some of the anticonvulsant medications, including carbamazepine, divalproex, and topiramate, may reduce some of the emotional lability, aggression, impulsivity, and self-injurious behaviors that can accompany autism spectrum disorder. You know, I talked a little bit about well-controlled epilepsy and active epilepsy, and many of the studies combine both when we're looking at the percentages. What I think is really important to stress is that the cognitive, psychological, and social issues that can present in epilepsy can contribute or can continue even when seizures remit. So just because we've controlled the epilepsy doesn't mean that we don't see these other co-occurring conditions with epilepsy. It's the cognitive difficulties, the changes in mood, and limited social support, but also sleep disturbances that seem to impact quality of life the most. And so I'm going to look at quality of life now. The quality of life is really defined as a person's perspective of his or her position in life. So if I can't walk 5 blocks, but I'm not troubled by the fact that I can't walk 5 blocks, it's not impacting my quality of life, just as an example. Oftentimes, the quality of life of children with epilepsy is based on parent report. And in a novel approach, Nora Fade and company, it's a Canadian study, published in 2015, they looked at children's perception of their own quality of life. They actually recruited 480 children and youth between the ages of 8 and 14. Their intellectual functioning was above that red area that I talked about earlier. And what they found is that the most pressing issues related to their quality of life was mental health and social support. And it was a social support in terms of peer support and parental support that really fed into the child's mental health as well. If the support was there and their mental health was there, Those were the essential ingredients, and the children reported that they had good quality of life, even if they had lots of seizures. This is a different study looking at quality of life, also done by Nora Fade and her colleagues, and they actually compare the child's report with the parent's report. And when comparing the two, they found that the child and the parent primarily agreed in terms of the quality of life that the child was experiencing. When their opinions differed, it tended to relate to the child's perception of their peer acceptance. So a parent may not necessarily know that the child wasn't feeling like they were accepted by their peer, and so they saw differences there. And sometimes when a parent had a harder time adjusting to their child's diagnosis of epilepsy, they reported lower overall quality of life than what their child did. Given all these conditions that we're seeing in terms of cognitive skills, psychological, social, quality of life, I am a strong believer that screening, identification, and treatment of the co-occurring issues should be a part of standardized care for children and youth living with epilepsy. So together with a neurologist or the epilepsy care team, depending on where your child is being supported, you really want to discuss potential issues to watch out for. You can find out how you might obtain help in dealing with some of the issues should they arise. If you have quite significant concern, then you probably want to seek some professional help for your child, including mental health care professionals specializing in children and youth. Within the hospital, that tends to be covered in terms of costs. Outside, psychiatrists will be covered, but social workers and psychologists tend not to be, but they may be covered through extended health benefit plans. If there's cognitive issues, particularly at a young age, a parent might seek a cognitive development pediatrician to have some type of formal assessment done at an early age, which would be covered by OHIP, or take advantage of the assessments for children who are under 5 with a speech and language pathologist. If there's more pressing concerns, you might want to see a neuropsychologist for a comprehensive neuropsychological assessment. Ensuring the health and safety of students with epilepsy is really essential to promoting well-being, and I strongly believe that it requires a good partnership among families, the school community, and healthcare professionals. And parents do need to advocate for their children at school. Teachers and school professionals do what they do very well, but they don't have the medical background, and so the difficulties associated with epilepsy are often missed, and consequently they're unsupported. And so they need to, it can be empowering if you share information regarding a child's epilepsy and the strengths and needs of your child. You're probably all familiar with the Ontario Ministry of Education's policy program memorandum number 161, which relates to supporting students with prevalent medical condition. As of 2018, all school boards in Ontario, and there's 73 of them, are required to have policies and procedures in place to support students in schools who have prevalent medical conditions. And a prevalent medical condition is defined as those conditions that have the potential to result in a medical incident or life-threatening medical emergency. And epilepsy is currently one of those conditions. This legislation is designed to foster healthy and inclusive learning environment. I feel that right now the biggest piece is for epilepsy is on seizure safety. If you want more information about the policy or about some videos, fact sheets that can be shared with the school on epilepsy specific, those are documented. So it's Epilepsy Ontario currently has 3 videos and fact sheets that can be shared, and I believe the link is with Epilepsy South Central Ontario. I'm just putting one slide on looking at transition to adult care. This can be pretty stressful for families and children in pediatric centers and with pediatric neurologists. I think we have a lot of support, and it changes a lot going to adult care. So we really want to have a thoughtful, well-planned transition to reduce the risk of having adverse adult psychosocial and medical outcomes. So just in conclusion, epilepsy is really an umbrella term, just like ADHD is. It is represented by the seizures, including the auras, the seizures themselves, postictal effects, interictal discharges, and I've put the anticonvulsant medications here as well because there may be side effects. The cognitive consequences of epilepsy, the social consequences of epilepsy, so it came out in a different order, and the psychological associations. So overall, epilepsy is far more than a seizure disorder. I thank you for your attention, and I am going to stop sharing the screen so that I can answer questions that you might have. Oh, we can't hear you.
There I go. Thank you, Elizabeth, for all that information. It's a lot of information on co-occurring conditions. And one thing that I have noticed is a lot of families get a lot of labels, and then the child has all these labels. And how can we change that a little bit? Why do you think?
Yeah, so that's one of the reasons that I put that umbrella at the end of the presentation. I really think of child as having epilepsy, and then the epilepsy is related to the labels that might be associated with it. So a child doesn't have epilepsy, ADHD, learning disability, anxiety. They have epilepsy, and epilepsy is displayed as the seizures that they're having and those skills. Labels do serve to help others understand in general what types of needs a child might have. I think understanding it is associated with epilepsy is very difficult for people who are not medical professionals or experienced in epilepsy. So those labels really just serve so they can have a general sense, like teachers, for example, how they could support the child at school. But really, it's all related to the epilepsy. So they have one condition.
You mentioned ADHD, and I have advocated for families in the schools with the team analysis of a child. And I often will say, just be prepared because they're probably going to tell you the child has ADHD. And it's every time has been the case. So you're saying it's a diagnosis prior to the first seizure, or sometimes it's within the seizure episodic periods. Like sometimes people with already a diagnosis have had that the ADHD diagnosis. So you were saying 33% meet the criteria for ADHD. So is there a misdiagnosis, or is this the way that this is the available testing that we're working with?
So ADHD is diagnosed based on symptom presentation. So there's kind of a checklist that you go through. I think that, because of whatever happening with the neurons that's causing the seizures in the first place, it also underlies some of the skills that we have. And attention is readily disrupted by lots of different things. So you just even think of somebody who doesn't have epilepsy, our attention is effective if we are sleep deprived, for example. So when there's disruption to the neurons, one of the skills that's going to be disrupted is attention. So you can get diagnosed with ADHD after you're diagnosed as well. I just wanted to make it clear that sometimes we see the difficulties with attention beforehand. The underlying reason why a child might meet criteria for ADHD might differ than for classical ADHD, but they're still showing the symptom presentation in order to get the diagnosis of ADHD.
And so a similar path would be taken to support the child at school.
Absolutely. So
Yeah.
all of the strategies that the school use to support other children with ADHD are going to be effective for a child with epilepsy. And a child with epilepsy can go through a medical trial to see whether they might benefit from a stimulant medication. All medications, I know that that's really hard to hear for a parent with a child with epilepsy because their child's already on a medication, or maybe 2 or 3 or 4. But trials are short-lived. I mean, it can be a day, it could be a week, it could be for 7 years. If it's tolerated and you see the benefit, then it's going to allow a child to engage better at school and be more successful in that environment. About 70% of children living with epilepsy do benefit from stimulant, who meet the criteria for ADHD, do benefit from stimulant medications. And that's actually the same as classical ADHD.
Oh, great. Great information. You mentioned the high risk for cognitive challenges in children is that there's early onset, the infantile spasms, more than one seizure a day, 2 or more meds, and this is children. So the majority of them are experiencing the cognitive challenges. So after puberty, is there a difference between getting a diagnosis prior to puberty and then after puberty? So in youth and adolescents?
Yeah, that's a really good question. So, because a lot of the brain development has happened by puberty, then the seizures aren't impacting a developing brain. For younger children, you've got ongoing seizures impacting the developing brain, not allowing the typical development to happen the way it should be. So for adolescents, a lot of the typical development has already happened for them, and so they do seem to fare better.
Well, the children and youth with their academic progress, a lot of you mentioned self-esteem and building that self-esteem is really helpful. And I find at our camp that's the goal, is increasing self-esteem, increasing self-confidence.
Mm-hmm.
And we get such great feedback in the fall from parents because the kids go back to school with all this confidence, and they do things that they don't do at camp. So they get, or they don't do at school. So parents are reluctant to send their kids to on a field trip to go swimming or horseback riding or rope climbing, but they do all that at camp. So it's the self-confidence building and the improvement of quality of life. That's where we come in as a community agency, trying to help families with that.
I think that is really great. And oftentimes when I'm talking with parents, kids have some type of real strength or something that they love. And I think it's really important to help support self-esteem at home by allowing them to have success in that area that they enjoy so much. So they have this area of strength. It is really nice that there's a safe environment, such as the camp that you run, for kids to kind of put epilepsy on the back burner and to just be themselves and to be able to participate in the activities that they're doing. I think that it's, you talked about the restrictions at school, and we really try to encourage participation in school activities. Although it might seem like it's limiting a child's physical activity is the best interest for him or her, doing so can encourage social isolation and interfere with the opportunities to learn and practice those important motor skills, executive functioning, and social skills. So like group sports is really helpful for developing planning and anticipation and those types of skills related to executive functioning. So really every effort should be made to ensure that a child participates in the physical activities, including gym, a recess, lunch, and extracurricular sports, and well as field trips. Sometimes I do know that a neurologist does recommend restrictions due to treatment or some specific risk due to a child's epilepsy. And so in those cases, they will write a letter to support those restrictions at school, but they need to be really specific in what's included in terms of what the restrictions are. And if the restrictions are removed, then they need to do an updated letter to remove that. You don't want the school telling you that your child's restricted. It's really up to the neurologist in a medical condition to do that.
Sometimes it's the parents, sometimes it's the schools.
Yes,
And
that's very true. So, which is really why I'm saying you
yeah.
do want to encourage your participation, just because of its importance in so many different aspects of their life.
Well, and we've participated in several research projects initiated by different doctors, and we were part of the FIED study as well with quality of life. But as well, we did participate in a study with regards to physical activity, and I think it's kind of the outcome everyone was expecting is that it's a healthy life. If they get some physical activity, it helps them mentally and emotionally as well. So
Oh, absolutely.
I know at camp they're exhausted at the end of the day. You are popular. We lots of people know you. I have, and speaking of camp, so hi, Dr. Kerr. I hope you're doing well, from Devon's mom.
Oh.
And there's a couple other ones. Yeah. So Alicia says Dr. Kerr is an amazing doctor and has helped my son tremendously in her epilepsy classroom at 6 kids. That was, and there's lots more. But that was, it's just
thank
lovely.
You. Actually, I get emotional, but thank you very much. I appreciate hearing that.
Yeah. No, I'm just looking at the chat box. We have some other questions here. Oh, someone's asking, can excitement cause seizures? So I find every time I get excited about something, I have a seizure.
So I think different children have different triggers, and I think it's really important to watch your child and to think about what happened right before the seizure. And if you're seeing that happen, there might be an overexcitation, which is, for having a seizure is an overexcitation of the neurons itself. So that could be a trigger for your child. So you want to be able to document the pattern, and you share that with a medical doctor.
Okay. What's a common question you get from parents concerning epilepsy? Schools often focus on the physical disability of epilepsy and less so on the cognitive, psychological, and social well-being. What would your recommendation be to address this? And it's a two-part question. Should their IEPs focus on this instead of a physical disability, especially when their seizures are well controlled?
So my experience with schools is that they sort of have an inverted triangle of where their needs are, and the physical safety when they hear of a child having epilepsy is their number one priority, and they want to really make sure that they've got a plan in place and that they know how to respond if a child has a seizure in their classroom. And I think that that's reasonable. It might not be something that they've experienced before in their classroom, and they might not be feeling completely confident in working with a child with epilepsy. So I think that with any child with epilepsy, whether it's well controlled or a child is still having seizures with it, it's really important to share information about your child's epilepsy with your child's teachers and other school personnel in order to foster a healthy adjustment for your child in the classroom when they're participating at recess or on field trips, sporting activities, and the like. Again, teachers and school personnel are not health professionals, but they do play an important role in supporting and ensuring the safety of students with epilepsy. I find that sometimes schools have a general knowledge about epilepsy, or they've known somebody with epilepsy, and so they think they know everything about it. But what they really need to hear is specific information about your child's condition and its management. So if your child is well controlled, You still are going to fill out a seizure safety plan, but you're going to get rid of that top concern almost immediately because your child hasn't had any seizures, well on medication for 2 years, let's say. The next concern often is regarding behavior, and my feeling is because that behaviors can disrupt the school environment and other kids in the classroom. So you might want to talk about the strengths that your child has in terms of monitoring themselves, and also the weaknesses that you see for your child, and what types of supports you envision for your child in that classroom. And the next piece comes the social, because that can cause some issues, and really the cognitive piece is the last that they become concerned with. I think in presenting your child's information, you want to cover all of the pieces. So you want to describe what your child's seizures look like, if they are still having seizures, and how often they occur, how it's best to support your child when they have a seizure. You're going to outline the medications. And then you're going to talk about the strengths that your child has and highlight any cognitive, psychological, whether it's behavioral or emotional, and social consequences that your child might have, and what you find at home works for their success. I hope I answered the question.
Yeah. Thank you. The two most common that you mentioned in your presentation, the two most common co-occurring conditions would be the psychological consequences of anxiety and depression. And
okay,
go ahead.
Yeah. No, that's fine.
I'm just saying some of it due to it's a fear of having a seizure, embarrassment, and how can we help children overcome the anxiety and the depression?
So I do think that a lot of the anxiety is due to the uncertainty of having a seizure. It's the unpredictability. So they're often in wait. And then I would say that it really happens at around 10 years of age, where I start seeing the embarrassment of having the seizures in public. The other younger kids just kind of go with what it is. So that's going to increase the anxiety there. We can't really take away that unpredictability of the seizures if that's what they're living with. But I think that a big part of children living well with epilepsy is understanding what epilepsy is, and understanding their experiences for themselves. So I think a lot of education needs to be done for children, with giving increasing amounts of information about the condition as they get older and can understand it.
Another question, thank you. Another question, hi, Dr. Kerr, happy face. The response delay you spoke of, so I'm thinking, trying to find that word. It's to catch or move out of the way, sorry. Can it also show physically? So example, if a ball's coming at you, can it delay your coordination or your ability to catch it?
Oh, for certain. Yeah, and that's partly making the judgment, anticipating. It's trying to set the brain sending the signals to the hands. I got to move up and pacing that time. So we do the study that I talked about in Sussex, England. It was done in 2014, and they recruited essentially all children within a school board who had active epilepsy, and they would have said that the most frequent co-occurring conditions include a developmental coordination disorder, and I think part of that relates to that processing speed, where the signals are not happening fast enough for them to coordinate their motor functioning in a timely manner. And certainly we see that slower speed when children are doing output on motor tasks with a pencil as well.
Good, yeah. Is it strange for someone who had infantile spasms that went away to have them come back in their late teens?
They wouldn't be called infantile spasms anymore. Infantile spasms is a really specific condition, which a neurologist would be better able to talk about than I would. But we sometimes see children who have had infantile spasms who have them under control, and then later, at some later time, do present with a different type of seizures. And they could be spasms. They could be motor spasms, but they wouldn't be infantile spasms.
That makes sense. I think this is our last question. Are there any studies that confirm that puberty for boys increases seizure activities? There's a family convinced that this is what's going on with their son. 3 different meds and seizure free for a year. After a long road, but literally the month high school ended was when the seizures eased, so to speak. Okay.
That they started again. So I think we do. I mean, I can't answer the question about the puberty piece. I think that the brain's going under lots of different changes, and there are different periods of time for whatever reason that people are susceptible. Over time, if the medications weren't increased, it might be that the medications were doing its job, but with weight gain, because somebody is growing, then the dosage is not as effective for the weight, and so there might be some breakthrough seizures, but that might be a little bit different than the puberty piece. I think that that question is best raised to a medical doctor. So I'm sorry, I don't have a better answer for you.
Well, thank you so much. This has been so informative. The educational videos that you mentioned are on our website, and they will be on, and so it's epilepsysco.org. And as well, we will be having some more seminars coming up. We just haven't firmed up our topics yet. And thank you so much for joining us, everyone. And Elizabeth, stay with us for a second, but I thank you very much for joining us.
Thank you.